Oh, hello, everybody.
Hello.
Hey, sorry, guys. Uh, uh, yeah, thank you for waiting. I'm sorry because we got a power outage, I think since last night, and then I didn't really know what happened, and I have to drive to San Francisco. So it's not the best time to drive through this Bay Bridge. Let me. Mhm. Hey, can everybody see this?
Yes.
Yeah, thank you. Thank you for waiting. Let's start. It's a little bit late now. So yeah, so let's start with the lymphatic system. Me that what I want you to remind about lymphatic system is number one, the right side of the head and neck, right upper limb, and right thoracic region. They drain in one different way, and the rest of the body have a different drainage system. So the left half of the head and neck, left thorax and left upper limb, and the rest lower part of the body, it will drain into the thoracic duct. So that is one thing I want you to take it from lymphatic system. So I believe we all remember that right side of the head and neck, right chest, right thorax, and right upper limb, it will drain in one different way, and the rest of the body drain into the thoracic duct and drain into the uh, the junction between the the brachiocephalic and subclavian vein. And what is the job of the lymphatic system? The job of the lymphatic system is to carry everything left over from the arterial and venous system anastomosis. So as we remember from the heart will pump out blood, which is through the arterial system, can and finally gradually become smaller. The largest artery is elastic artery, and the size smaller, medium size artery. So the largest elastic arteries are aorta, like arch of aorta or abdominal aorta. They are very elastic. And the medium size arteries are the organ arteries, for example, like radial artery, ulnar artery, or renal arteries. So these are the medium sized muscular arteries, and finally become very small little arteries, which is called arterioles. And then arterioles became capillaries, capillaries on the arterial end, and gradually change into venous end, and finally became small little venules. So there is these capillaries. As you remember, there are three types of capillaries: continuous capillary, fenestrated capillaries, and sinusoidal capillaries. So yes, at the capillary level, there will be exchange from the arterious oxygen into the tissue. From the tissue, carbon dioxide will be taken back into the capillaries. The same thing like nutrients, like all the metabolic waste, and there will be exchange at the capillary level. And anything left behind, so any fluids left behind, which is from the capillary and seeping out, but the veins cannot take it back, that will be left behind. The large molecules protein will be taken picked up by these lymphatic vessels, and that lymphatic vessels will gradually get into the venous system. So there is nothing left behind. Everything will be taken back. Everything will be taken back by the lymphatic venous system. If anything left behind, lymphatic system will take it back. And here we have to remember the let's say the hierarchy or gradual progress. So lymphatic system, the smallest portion of the lymphatic system is capillaries. So lymphatic capillaries will pick up anything left behind, and finally we march together. These capillaries will march together to become the collecting vessels. Yeah, and these collecting vessels will drain into the lymph nodes. These lymph nodes will filter the lymph. Anything like foreign, for example, like bacteria, virus, the lymph node will sieve and contain it inside the lymph node. And then the rest of the lymph, after filtration, it will go out from the lymph node, and it will become lymphatic trunk. So the lymphatic coming from the lymph nodes will join together to form the lymphatic trunk, and finally become lymphatic duct and will drain into the large veins, usually superior vena cava, or the junction of the, on the left side, the junction of the subclavian and the brachiocephalic. So that is the thoracic duct, which is the main duct for the rest of the body, other than the face, head and neck, right thorax, and right upper limb. And so that is, this slide is trying to explain what is the job of the capillary. So these are capillaries, blood flowing through the capillaries. Oxygen will be delivered to the tissue. Carbon dioxide from the tissue will be taken back into the capillary. The same thing, like the glucose will be delivered to the tissue. The metabolic waste such as urea will be returned to the into the capillaries. And if there is anything left behind, lymphatic system will pick it up. So that is a very smart way to clean up in the periphery level and the cellular level. And I want you to remember these, the hierarchy, like lymphatic vessels to start with, and then finally drain into the lymph node. Anything coming out from the lymph node will join together to form the lymph trunk. Lymph trunk will join together, lymph duct, and this will drain into the venous system. So this is the lymphatic system, which is not difficult for you, I hope. So the job of the lymphatic system is to collect excessive fluid from the periphery, collect the leaked protein. The proteins are too big. Sometimes venous capillaries cannot pick it up, and they return everything back into the venous circulation. That's the meshwork. So the lymph, the arterial and venous capillaries, lymphatic capillaries, they are all meshed together. That's the only way they can pick up anything left behind. So it is a reminder of the capillaries, different types of capillaries, continuous capillaries. We talk about this in the blood vessels. And if you remember that capillaries they do not have tunica intima media adventitia. They only have the endothelium, which is the simple squamous epithelium, but it is because in the blood vessel we change the name endothelium. Actually, it is a simple squamous epithelium, and the junction between one epithelium and another epithelium, the junction is tight, and these epithelium, they do not have any perforations. This is the continuous type of capillaries. And fenestratus, you can start seeing the little holes in the endothelial cells, which might help with the transfusion and exchange. So this type of capillaries, we want to use it in the kidneys, organs such as kidney, because kidneys are organs for the filtration and secretion. So therefore, we will use this type of capillaries, and really open, like the fenestration are big fenestrations, and the gap between the endothelial cells are big. These are called sinusoidal capillaries. They will be used in a big exchange, such as liver, such as spleen. So these are bone marrow. So these sort of organs we use this sinusoidal capillaries. But lymphatic capillaries are slightly different. Lymphatic capillaries are slightly different because they are one way. They are only from the periphery to the systemic circulation. There is no lymphatic coming from systemic circulation to the cell, because the job is to carry all the excess fluid and metabolites from the periphery to the center. So lymphatic system is one way from periphery to the venous system, and therefore their starting capillaries are blind pouch. Yeah, as you remember, they are blind pouch, and the way they carefully construct is they are endothelial cells, they are flipping on each other, as you can see here. These lymphatic endothelium, so which is again simple squamous epithelium, but because it is in the special vessel, so we have to give it endothelial cell. And these endothelial cells, they are lying on each other like a little flap, like the way we do that for our roof, roof, little flaps lying on each other. And these little flaps, they are attached to the surrounding tissue with the filaments. So if there is any contraction or any tightness or any expansion in the surrounding tissue, these filaments will contract and it will change the shape of the endothelium. By doing so, it will open the channel, and the fluid from the outside the lymphatic can go into the lymphatic system. That is the beginning of the lymphatic system, which is the lymphatic capillaries, which is one-way blind pouch. And lymphatic capillaries, they are lined by this simple squamous epithelium. And it is closely related to the blood vessels. Of course, we have seen this already. And remember, those areas where we do not have lymphatics is bone, like anything hard. Let's say, just try to remember as anything hard. So the bone is really hard. Our teeth is really hard. And the bone marrow, and really soft CNS, because central nervous system, they cannot accept anything extra. So as we will talk about that in the central nervous system lecture, because if you think about our brain, and the brain is inside the cranium, the bone, skull bone is really tight and rigid, it cannot expand. So the cranium can accept the limited amount of blood, limited amount of artery, limited amount of veins, and the CSF, cerebrospinal fluid, and the brain substance. So only 4 things like the arterial blood, venous blood, the brain substance, and the cerebrospinal fluid. The brain can accommodate only these 4 with limited amount, really, really tight. So the brain will use a special vessel, which is the continuous vessel. There is no leakage, the brain cannot accept it, and the brain does not need lymphatics. So these are the organs where we cannot find lymphatic system, which means the rest of the body we have lymphatics other than these. And so as we remember from this diagram, we have talked about this again and again, so I'm going to skip it. And hey, remember, lymphatics from the gastrointestinal tract. So lymphatics, so as you remember, we talk about the gastrointestinal lumen. The gastrointestinal lumens, how many layers do we have? We have 4 layers: mucosa, submucosa, marcel layer, and adventitial layer. Even in the mucosa, we have the mucosa layer, epithelium, submucosa layer, muscularis mucosa. So like it is like mucosa, lamina propria, and muscularis mucosa. So all these cells will absorb all the nutrition. Like these cells are the cells lining of the gastrointestinal tract are usually columnar epithelium. They have the large capacity to secrete, and they have the large capacity to absorb. So everything from the gastrointestinal tract absorption, like for example, like if we eat fat, if we eat butter is 80% fat. The fat will be broken down finally into fatty acid. This fatty acid need to be absorbed from the gastrointestinal tract. And where do they go? These fat globules, these triglycerides, these fat globules are really big and the veins cannot take it. And therefore, the lymphatic system will have to take it. So the gastrointestinal tract absorption, lymphatic system from the gastrointestinal tract, which are called lymphatic vessels in the gastrointestinal tracts are called lectins. So this is a new terminology which we need to remember. That is the beginning. Lymphatic capillaries will become lymphatic vessels in the gastrointestinal tract. The lymphatic vessels are called lectins. They exist in the villi of the intestinal mucosa, and they will absorb digestive fat and carry it into the bloodstream. Of course, if that fluid, that lymphatic fluid is so much rich with fat, that will look like something like milk, and therefore we will call it chyle. Chyle is milk. So the milky-like structure, which is called chyle, is the lymphatics, which the lymphatics from the gastrointestinal tract called lectins will be taking and will be taking them to the venous system. So lymphatic pathways, we talk about the capillaries, we talk about the collecting vessels. Collecting vessels in the gastrointestinal tract is lectins. And these lymphatic vessels, superficial vessels will follow the veins, and deep vessels will follow the arteries. So usually arteries are deep inside the body and the veins are superficial, because we can, if we look on our arms, we can see the veins. So these lymphatics will be following the veins. They are thin wall vessels. Yes, capillaries, they are just endothelial cell. Lymphatic vessels, they will have the 3-layer tunica, intima, media, adventitia, like arteries. Yeah, because it is coming back from the periphery to the center, so there is no heart behind, and therefore lymphatic system is the low pressure system. How do the fluid from the lymphatic capillaries come back to the vein near the heart? Of course, like the vein movement, so muscle contraction, movement, arterial pulsation around the capillaries, we pump and push the lymphatics back into the systemic circulation. And lymphatic vessels, they will also have valves. So they are pretty similar to the venous system. So lymph nodes, now we got from the lymphatic vessels, we got to the lymph nodes. Lymph nodes, like it is kidney-shaped structure, diameter, it is about 1 to 2.5 centimeter, might be smaller than that, so might be like about 0.5 centimeter. So as we remember, as I say, any enlarged lymph node is, we got to take it seriously. Of course, you know, like so the enlargement, how big is it and how many enlarged lymph nodes, that is also important. We have to take that into consideration. Wait, let's go. So lymphatic vessels will come into the lymph nodes. At the same time, immune system will come into the lymph node. How do they do that? Because when we talk about that immune system, the bone marrow will generate the B cell and T cell. The B cell will stay in the bone marrow to get mature, but T cell, T lymphocyte, we have to go to the thymus and get educated in the thymus. Once they are educated in the thymus, this T cell, T lymphocyte, will be stored in the lymph node. So that is the junction between the body immune system and the lymphatic system. And I hope you remember, like the lymph nodes have cortex and medulla. Yeah, outer cortex, inner medulla. Where did we see that? We saw that in kidney. Where did we see that? We saw that in adrenal gland. So adrenal gland, lymph nodes, kidneys, they all have outer cortex and inner medulla. So these lymphatic drainage and they are significant lymph nodes, as we say, it is a little bit important, especially when you get to the clinical rotations. Superficial cervical lymph node, they will receive lymphatics from the head and neck. So any lymph nodes enlargement, of course, you know, lymph node enlargement need to be significant enlargement. Like, for example, might be more than 2 centimeters. That's the rough idea we tend to remember. Of course, different area, we have slightly different significance level, but let's try to remember more than any lymph node enlargement, bigger than 2 centimeters, bigger than or more than 2 lymph node enlargement. So that's a rough guide. So if we have like 3-4 lymph node enlargement, which might be the size might be 2, 3, 4 centimeter size around the cervical, around the neck region, we need to check the head and neck region. The same thing, like, you know, the axillary and inguinal lymph node. Axillary lymph node, we have to check the upper limb and the breast. Inguinal lymph node, we have to check the lower limb and the genitalia. So these are the lymphatic drainage sites. And mediastinal, if someone has cancer of the bronchus, trachea, so lungs cancer, they will drain to the mediastinal lymph nodes. Aortic lymph node, posterior abdominal wall. So kidney will drain into the aortic, para-aortic lymph node. Testes, ovaries, these are the retroperitoneal organs which are once inside the abdomen. Finally, they have to go to the pelvis or the scrotum. These are the originally retroperitoneal intra-abdominal organ. So therefore, if we suspect testicular cancer in the testes, we have to check the aortic and para-aortic, around the aortic region, para-aortic lymph nodes. So that is the significance. Of course, you know, any pelvic organs like bladder, uterus, we need to check the iliac lymph node. So this is the significance of our lymphatic system. So that is really, really important. It could be like if any inflamed, significant inflamed or big enlarged lymphatics, then what are we thinking about? We are thinking about infection, or we are thinking about the cancer, or it might be just like an autoimmune system, just our own immune system fighting our immune system itself. So whatever it is, lymph node enlargement, think about whether is it significantly enlarged or not, and think about the draining area. So that is the lymph node. As you remember, the lymphatic vessels will drain into the cortex portion. These are the cortex portion, and finally will be sieved into the medulla portion. Along their way, the draining lymph will be sieved again and again and again to make sure there is no bacteria, no virus, no foreign body. If there is anything there, the lymph node will be enlarged. The T lymphocyte will start to act on these structures. Okay, and finally it leaves from the central portion, which is called hilum of the lymph node, and it leaves the lymphatic vessels coming into the lymph node is called afferent vessels. Lymphatic vessels leaving the lymph node is called efferent vessels. So yes, finally the lymph drain into the lymph node will be filtered, coming in the afferent and then leaving the lymph node with the efferent vessels. That is a very clever filtration. So yes, so you can see the hilum now, and the outer cortex and inner medulla. So like lymphatic corpuscle. So this is the photographic, and look at the filtration here inside the lymph node. There will be macrophage, reticular cells, lymphocytes. Of course, this lymphocyte will be T lymphocytes. And hey, that's a reminder. If we feel a lymph node enlargement in the axilla, we need to examine the upper limb, the draining upper limb, and the draining breast. Yeah. So right axillary lymph node enlargement, right breast, and right upper limb, we need to check. And yeah, so axillary lymph node dissection. So the lymph node in the axilla here will be defined by the pectoralis minor. Yeah, pectoralis. This diagram has removed the pectoralis major, the big muscle on our chest, and now we can see the pectoralis minor. This pectoralis minor divide the axillary lymph node into the outer lymph node group, medial lymph node group, and middle lymph node group. What is the significance? That is significant for in breast cancer. So let's say if someone has breast cancer, and if there is no lymph node enlargement, hey, we are happy. There is no lymph node enlargement. Because if there is any lymph node enlargement in the axilla, we have to remove the lymph nodes as much as we can. If we remove the lymph node from the axilla, the lymphatic flow from the arm will got damaged, and that can give us a swelling, the poor lymphatic drainage from the arm back to the central venous system. So that is a very annoying. That is what we call lymphedema. So this, depending on which lymph node group involved, the stage of the lymphatics, a stage of the the breast cancer change as well. So lymphatic system, that is really important. So now we got into from the capillary, go along the collecting vessel into the lymph nodes. And finally, we got these lymphatic leaving the lymph node, we join together to form the lymphatic trunk. So these are the lymphatic trunks. I don't want you to remember in detail about lymphatic trunks. So which trunks, okay, yeah, it's good to know. But finally, what I want you to remember is this diagram, the final picture. I want you to have the bird eye side of you. You are seeing everything from the top and you are not going to too much little details. So this diagram is really, really important. And finally, this lymph tract will join to form the lymphatic duct. So one of the lymphatic duct we know and important is thoracic duct. Where does this thoracic duct start? Hey, it starts from the abdomen at the lumbar vertebra 1 and 2 region, or the lumbar and intestinal lymphatic vessels, all they form and join. And because everything is starting to join, there is a little bulge in that area. That area is called cisterna chyli. Yeah, cisterna chyli is the beginning of the thoracic duct, which is at the level of lumbar 1 and 2 region. Right, and that's cisterna chyli. And what's happened? So all these thoracic duct will finally accept everything into the thoracic duct, and it is for the left side. It will go into the junction between the brachiocephalic, so the one coming from the head and neck, and the one coming from the arm, subclavian. So that junction vein, the thoracic duct will go into that region. So what's happened to the right upper quadrant of the body? Like they will go into the many different things like right jugular, right subclavian, right bronchomediastinal trunk, or they might just drain into the inferior vena cava, or they might join into the right lymphatic duct. So it might be a little bit haphazard. It will just, they might join, they might not join, but whatever it is, they are separate from the left side of the body. But of course, and whatever it is, the lymphatics we have to drain into the subclavian and internal jugular vein, finally into the superior vena cava. Hey, this diagram is really, really nice. These are the final pathway of the lymphatics. What I want you to remember is thoracic duct. Where does the thoracic duct start? Here at the lumbar vertebra 1 and 2 level. The lymphatics from the vertebra and the lymphatic from the gastrointestinal tract, they will join together to form the cisterna chyli. And this cisterna chyli will drain, come all along the thoracic, and finally will drain into the junction between the brachiocephalic and the subclavian. On the right, the story is different. They might drain into slightly different way. So we don't really need to remember, as long as we remember the veins, you know, the right brachiocephalic vein, right subclavian vein, superior vena cava. Yeah, just say, you know, just say like that will be correct. Yeah, that is the cisterna chyli. I want you to remember cisterna chyli. Okay, so this is the diagram of the lymphedema. It is really sad, guys. So one of the lymphatic pathway is blocked. Like, you know, it might be blocked in the lymphatic vessels. Capillaries might not function well. Lymphatic vessels might not function well. The valve might not work. the lymph nodes get swollen with infection or radiation. You know, if someone has radiation to the lymph nodes, those lymph nodes will get fibrosed and scarred. These lymph nodes cannot drain any lymphatic anymore. And the draining region, draining lymph, draining parts of the body will get lymphedema. Look at the severity. It is a very mild stage. It is just slightly bigger than the other side. If it is getting worse, it is bigger, and finally, look at that. It is a really sad. Nothing cannot do much because, you know, because the way is blocked already, and it is really difficult. And because of the swelling, the skin will get stretched, the skin will get weep, and the secondary bacteria skin infection can go into the skin. Cellulitis is very common. It is really, really sad story. That is the lymphedema. Okay, so how many types of lymphedema do we know? We know 2 types of lymphedema. They are primary lymphedema and secondary lymphedema. Primary lymphedema, it is rare, and it is because congenital. That person is born with the defect in the lymphatic system. And that like, for example, their lymph nodes are not functioning well. Their lymphatic vessels are not functioning well. The valves inside not good. But more common is secondary lymphedema. Secondary lymphedema, of course, those patients who has got breast cancer, vulvar cancer, penis cancer. So the breast cancer, like 20% of the breast cancer patient will develop lymphedema. That is really sad. What about vulvar cancer? Even worse, like 1 in 2, 50% of those patients with vulvar cancer, they are going to get this lymphatic blockage and lymphedema. And about 30% of the penis cancer patient will get lymphedema. So that is a really, really sad story. I hope at some point you are the guy who is going to help these sort of patients. And if you are helping and working with these patients, I want you to remember this lymphatic system. Why did this happen? Hey, look at that enlarged lymph node. Check it is really big. It is more than 2 centimeters. Hey, check the head and neck. Look inside the mouth. Look inside the throat. Look inside the ear. Make sure there is nothing wrong with the head, because this is in the superficial cervical lymph node enlargement, which is really big. That's our job. That's your job, and that's my job. That's our job to check. We should not miss it. And now we come to the immune system. Immune system is important for the, like, I believe we all know, like, it is important for the against the disease, against the infection. Like, there is always something wrong in our body, and immune system detect it and they delete it. So let's say if we have a competent immune system, we will be protected against infection, we will be protected against cancer. If we do not have competent immune system, if our immune system is not functioning well, and these people, you know, they tend to get cancer, they tend to get infection. So that's immune system is really important. But like on the opposite side, the immune system is really, really strong. And it is so strong that this immune system is fighting its own body. So that is what we call autoimmune disease. Like, I believe you all know many autoimmune disease, like rheumatoid arthritis, systemic lupus erythematosus, and many autoimmune disease flying around. So because this immune system is overactive and fighting its own body. So this immune system really important. It is also connected with the lymphatic system. Where do they connect? They will connect in the lymph nodes. So important. The Giro, so that's the immune system. And so here, I want you to remember, like, have a general bird's eye side of view as a clinician, might be as a nurse, might be as a doctor, or might be as a medical scientist who has to think about what is the body defense? What is our body defense? Our defense mechanism in general, of course, in general, very general, it can be divided into non-specific and specific. So non-specific could be barriers like our skin. Our skin is part of the immune system because it is the physical barrier. It is a physical barrier. And the complement system and phagocytosis. So these are the non-specific. It doesn't matter. It might be virus, it might be fungus, it might be bacteria. It doesn't matter. These three systems, body, skin, we fight it. Complement system, we fight it. All the inflammatory cells, neutrophil, they will fight it. And phagocytosis, neutrophil, phagocytosis, they will do that, whatever the invading organism is. But there is another side of the body defense mechanism, which is very specific. This bacteria, this body defense. This virus, this defense. So just like the way, coronavirus, we have to stimulate our immune system to get the immune system to train for these body defense mechanism just to attack the invading coronavirus. So this coronavirus immunization, it is just training us to help us to protect very specific against the coronavirus. It is not useful for pneumonia. It is not useful for influenza virus. This coronavirus vaccine is just for the coronavirus. So this vaccine is just training our immune system to attack that particular virus. It is not specific. It is specific. So the specific, it could be natural or artificial. Natural means we are born like with mother's immunoglobulins, like IgG, IgM. The mother will give us, our mom will give us for immunoglobulins, but they don't last long because they will be depleted. Let's say by 4 months, 5 months, 6 months, the immune system from the maternal immune system from the mother, they will gradually deplete. By that time, for the first 6 months of the month, we have to develop ourselves to get the specific immune system. So therefore, the immunization in babies, this happened at 2 months, 4 months, 6 months. I believe you remember that because this is a time where we have to train our immune system so that when the maternal immunoglobulins depleted at 6 months, we are ready to some extent to fight the invading, and we have some sort of specific immune system already. Antibody mediated, cell mediated. Antibody mediated will be directed by the B lymphocytes, and cell mediated will be directed by the T lymphocytes. So I want you to remember this overall picture of our body immune system. And lymphocyte, we talk about lymphocyte, B lymphocyte, T lymphocyte, we talk about that. And there is also natural killer cell. Natural killer cell is coming from the T lymphocyte. What are the lymphatic organs? So we talk about the primary lymphatic organs and secondary lymphatic organs, isn't it? I believe you all remember that. What is the primary lymphatic organs? Primary lymphatic organ is where the lymphocytes generate. Primary lymphatic organs are bone marrow and thymus. Yeah, primary lymphatic organs are bone marrow and thymus. So it is the site where the lymphocyte, either B or T lymphocyte, mature, grow, mature, and educated. Bone marrow and the thymus gland. So primary lymphatic organs are bone marrow and thymus gland. Secondary lymphoid organs are spleen, thymus, spleen, lymph nodes, tonsils, small intestine, appendix. So these, so you remember when we're talking about the gastrointestinal tract, mucosa-associated lymphoid tissue, MALT, mucosa-associated lymphoid tissue, MALT. So these are the secondary lymphoid organs. So our spleen is secondary lymphoid organ. So for those people who has splenectomy because of the trauma or because of the overactive spleen, like spleen is destroying the blood cells, they have to remove the spleen. So no spleen means these people will be deficient with the immune system. So spleen, lymph nodes, tonsils, and small intestine. Small intestine, if you remember small intestine, I want you to remember MALT, M-A-L-T, mucosa-associated lymphoid tissue. These are the lymphoid. Infection and antigen, body defend the macrophage, body defend with the macrophage and lymphocytes. Each lymphocyte, when there is antigen, what is antigen? So antigen is anything foreign to the body. So it could be like protein, it could be bacteria, it could be virus, it could be like little foreign body, like little prick. That is anything other than our self is foreign body is antigen. But usually, of course, protein and glycoproteins. And when there is any foreign antigen, and this lymphocytes will recognize and we will go and attack it. So lymphocyte septides, we said T lymphocyte, B lymphocyte, and there is also natural killer cell, which is T cell. And this is the way B lymphocyte and T lymphocyte go and attach the foreign, attack the foreign antigen. So I hope you all remember T lymphocyte, B lymphocyte. The T lymphocyte will go and attach to the foreign antigen, and then they will just back out, and this foreign antigen will disintegrate. That is the way T lymphocyte works. And B lymphocyte will have to change into plasma cell. Plasma cell will secrete antibody, and these antibodies will go and take care of the bacteria or antigen, and the macrophage will come and digest the antigen antibody complex. So the B lymphocyte and T lymphocyte difference. This is the T lymphocyte. The T lymphocyte will bind to the target antigen, target cell, and they will secrete protein, which will lyse the antigen, and finally it's just back out, and the antigen will got lysis. And this is the plasma B lymphocyte, which will change into plasma cell, which will secrete antibody. Yeah, B lymphocyte will secrete antibody. Natural killer cells, they will act as a T cell. It is just they do not recognize any specific antigen, so they will just like help. It's a helper killer cell. And this is where we talk about from the bone marrow, lymphatics, bone marrow will produce B lymphocyte and T lymphocyte. B lymphocyte will remain in the bone marrow. T lymphocyte will go to the thymus, and thymus will educate the T lymphocyte, and the bone marrow will give the B lymphocytes. So that is cytotoxic T cell, helper T cell, CD4, CD8. I want you to have this. Is more of a detailed immunology, which we usually teach in microbiology, natural killer cell, memory cell. But don't forget cytotoxic and helper T cell. They are T cell. Yeah. So CD4 cytotoxic is CD4 and helper T cell is CD8. So frequently infected mucosa, so lymphoid tissue, where do they have it? Gastrointestinal tract, urinary tract, respiratory tract, renal tubules. So that's the lymphoid organs. We talk about that. Thymus gland. Thymus gland is just, you need to have some working knowledge of thymus gland. As we remember, like, you know, like lymph nodes, ovary, kidney, thymus, they will have the cortex and medulla. Cortex and medulla. They will have multiple lobules, not important. And the thymus gland will change with age. So the best time for the thymus gland might be about 20s. Then after that, 30, 40, 50, the thymus gland gradually regress, get smaller and smaller and smaller. This is where our thymus gland is. It is just behind the sternum, which is in the anterior mediastinum. Anterior spleen, just a touch about spleen. What does it do? What does it do? It removes the antigen from the blood, and it removes the age. So RBC, let's say RBCs, red blood cell, how many days do they stay in our circulation? About 120 days. That's average RBC, isn't it? So 90 to 120 days, that is the RBC staying in our circulation. So this RBC, when they are old or when they are deformed, then this RBC will be cleaned up, will be taken away by the spleen. So that is the one function of the spleen. And the other function of the spleen is, it is for the immune system. And if you divide the spleen, cut the skin, you will see the white part and red part. White part is, let's try to remember as red part is for the blood. It's red, it's for the blood cells, and white part is for the immune system. What am I talking about? What am I talking about here? So we are now cutting the spleen into half, and you look at that, the white part, which is here, white part, and red part. Red part is for the red cell removal, white part is for the immune system. And this is the anatomy of the spleen, and look at the splenic artery. Splenic artery is really big, tortuous, it is running posterior to the pancreas, and it will go into the hilum of the spleen. Right, then tonsils, palatine tonsil, lingual tonsil, and tuber tonsil. And cancer of the penis, don't forget to check the lymph node. If you see the ulcer, don't forget to check the draining lymph node. If you see the draining lymph node, don't forget to see the draining region. Cancer of the penis, cancer of the vulva, vagina, and the head and neck cancer. That is the only way one important way we can notice head and neck cancer. Don't forget that. And breast cancer, breast lamp, check the axillary lamp, check the breast, check the arm. So that was the immune system. And now let's go to the second lecture, lymphatics and immune system. Gastrointestinal tract, yeah. I believe we are strong to face the gastrointestinal tract. So hey, we take about 3 lectures to sort out this gastrointestinal tract and abdomen. So let's try to gather together. So like it is a cumulative knowledge, because you have seen the lymphatic system already. You have seen the gastrointestinal system already. So like, let's try to remember everything together. We talk about the 4 quadrants of the abdomen. It is important for those students who are going to work with the human beings. So because these quadrants will indicate what is underneath and what is wrong. So if somebody say, I have got this right upper quadrant, so I've got pain around here, which is in the right upper quadrant, what we need to think is we need to think about the liver, gallbladder, and might be stomach, might be not sure, might be transverse colon. Hey, so that sort of relationship. So if somebody says something, we are trying to relate with the intra-abdominal organ of the abdomen. So if we want to be a little bit more specific, we need to know the 9 regions of the abdomen, and that is a little bit more specific for those going to nursing, for those going to medical school. This is a must. So they will gradually home you into the 9 regions of the abdomen because it is more specific. And skin incisions. So let's say if you are doing a physical examination on somebody, and if you look at the tummy, and I want you to know what sort of operation they have by looking at the scar they have on their tummy. So if you see an incision just above the pubic symphysis, it is like a U shape, like around the skin crease. You all know that it is a cesarean section. That section is called the Fenester incision. The name of the skin incision is called Fenester incision. Of course, it is so good to go to the uterus. It is so good to go to the urinary bladder. It is so good to go to the prostate gland. So those, if you see this incision, number one, whether they have a delivery with the cesarean section or prostate operation, bladder operation, or the uterus operation. So that sort of information I want you to relate. And if you see a scar in the right iliac region or right inguinal region, then I want you to think what type of incision it is. Hey, that incision is for the appendix. Of course, these incisions are very, very rare. That is what we call Gabel's incision. Gable incision, it is like a big opening into the tummy, which is, for example, like the liver transplant, that sort of incision. And Kochka's incisions or subcostal incision, just below the costal cartilage of the rib, subcostal incision, it is somewhere to operate on the gallbladder. Hey, gallbladder, Kochka's incision. But this Kochka's incision is gradually become rare and rare and rare because these days we are trying to do gallbladder surgery with the laparoscopic. Yeah. So because this incision is a little bit annoying for the patient, which is big, which is a little bit distractive, and therefore we try to avoid this Kochka's incision. But sometimes we have to do it. And like a midline incisions, like midline, just off the midline, so paramedian incision. And again, like midline, as you remember, we go through the linea alba. The linea alba is the place where right rectus sheath and left rectus sheath meet in the center, and then there is no blood. It is just white fibrous layer, linea alba, linear line, alba, white line. There is no muscle, linea alba, which is for the midline incision of the abdomen. And if we are thinking of getting somebody's skin, as a surgeon, we need to know what we are cutting. We are cutting the skin. Skin means epidermis and dermis. Underneath the skin, we have hypodermis. And then we have the deep fascia. And then finally, we get to the muscle, or finally, we get into the abdomen. So I want you to have a thinking brain when you are doing something. Yeah. If you have a scalpel in your hand, and if you are making a skin incision, then that is what you are going to cut through. So epidermis, dermis, hypodermis, deep fascia, and might be muscle in the extremity, or might be the peritoneum in the abdominal cavity. So we talk a lot of muscles. We talk a lot about these muscles in our abdomen. I believe you are pretty fed up with that. External oblique, internal oblique, transversus abdominis. They are coming from the side. And we have the vertical straight muscle, rectus. Rectus means straight. Rectum means straight. Rectus means straight. Straight muscle in front, right, left rectus and right rectus muscle here. So let's, in the back here, this is what we call latissimus dorsi. Latissimus dorsi, this is the trapezius muscle. Latissimus dorsi can attach to the spine region as lumbar fascia. We will talk about the fascias around the spine when we talk about the lower limb muscles. So this is the lumbar fascia. This is the ilium and iliac crest. And hey, we talk about these muscles, external oblique, internal oblique, and transversus abdominis. But actually, we have two more layers. We have the transversalis fascia, and we have the peritoneum, which we haven't talked about. So external oblique, internal oblique, and transversus abdominis. It is the internal oblique abdominis, which will split into anterior and posterior portion. Anterior portion of the internal oblique will bind with the external oblique to form the anterior rectus sheath, which will go in front of the rectus muscle. Posterior portion of the internal oblique will join with the transversus abdominis, which will form the posterior rectus sheath, which will go posterior to the rectus muscle. And this anterior and posterior rectus will come and meet in the center with the opposite side, and that is what we call linea alba. So now we understand that this splitting and combining, they are only above the arcuate line. So below the level of arcuate line, all these fascias from three muscles, they will go in front of the rectus abdominis. That is what we talk about when we were talking about the inguinal region. So these fascias, they go split and go posterior, anterior, above the arcuate line. Below the arcuate line, all the fibers, they will go in front. So posterior, below the arcuate line, posterior to the rectus, we only have transversalis fascia and the peritoneum only. So where is the arcuate line level? It is the midway between the umbilicus and the pubis symphysis. So yes, all these knowledge will gradually come together. Yes, so it's just one after another after other. That is the knowledge, because we cannot take everything straight away. So yes, this is the drawing. I believe you are fed up with this. This is a really good example. I want you to draw this external oblique, internal oblique, and transversus abdominis. And we have two more layers, transversalis fascia and the peritoneum. Body cavities, we have already talked about already. If we open the abdomen, that is what we are going to see, the omentum, greater omentum, which is covering. And if we talk about the gastrointestinal tract, of course, it starts with the mouth, oral cavity, oropharynx, esophagus, and this is the esophagus, which will go pass through the diaphragm, go into the abdomen, and suddenly get dilated. That is what we call the stomach. Stomach has lesser calf, which is the small curvature, and greater calf, which is the bigger curvature. And stomach will continue as the duodenum. Duodenum will continue as jejunum. Jejunum will continue as ileum. Ileum will go into the cecum. The junction between the ileum and cecum, there is a valve, which is the one-way valve. So only the content from the ileum can go into the cecum. Cecum contents cannot go back into the ileum because of the patent ileocecal valve. So this ileum and cecum will go up as a ascending colon, cross to the left side as the transverse colon, come down as the descending colon, and finally twisting like that as a sigmoid colon, and will finally go down rectum and anal canal. Yes, this diagram, I believe you guys have seen it when you do the homework. So I want you to have a good knowledge of the gastrointestinal tract anatomy and relating to the clinical application. This is the barium. Barium is radio-opaque. Somebody has swallowed the barium, and barium is inside the stomach, leaving the stomach, going into the duodenum. Duodenum will go into the jejunum. Look at that jejunum. Jejunum is what we call concertina effect, like an accordion effect. It is just like a mesh squash like that in the center. Jejunum, and finally that we get into the ileum, I-L-E-U-M. I-L-I-U-M is our pelvic bone, iliac crest, ileum, and we finally carry on into the cecum. But what I want you to remember is jejunum is concertina effect, or the what do you call that? The accordion effect. And jejunum is just character leg. It is just like a little plastic bag which you fill with water. That's all. That's the ileum. And now colon, as we all remember, colon, the characteristics of the colon. Number one is hostrations. Look at the hostrations here. Bomb, 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 bomb. Hostrations. Colonic hostration, that is one feature of the colon. The other two features of the colon is appendices epiploicae, the little fat, I hope you remember, and the tinea coli, like those longitudinal muscle, which is tethering the colon in their long axis. That is because of the tinea coli, we have the hostrations. So this is the colon. So the whole picture is called gastrographin, not barium, gastrographin. Gastrographin, like swallow and then just take X-ray after X-ray after X-ray. And gastrographin is in the stomach, leaving the stomach in the jejunum, going to the ileum, from the ileum into the cecum, ascending colon, transverse colon, descending colon. So that is the gastrointestinal tract, and this is lovely. You know, the cecum, ascending colon, transverse colon, descending colon, sigmoid colon, rectum, and anal canal. Now, I want you to remember the flexure of the colon from ascending to transverse and from transverse to descending. This happened close to the liver, therefore we will say hepatic flexure or right flexure of the colon. This happened close to the spleen, which is called splenic flexure or the left colic flexure. So I hope, you know, we all remember these. And blood supply of the intra-abdominal organs. As you remember, I hope you all remember 5 blood vessels, 2 coming from the side, pair vessels. They are renal artery and gonadal artery. 3 single and paired vessels. They are celiac, superior mesenteric and inferior mesenteric artery. Like celiac will give supply to the foregut, superior mesenteric will give supply to the midgut, and inferior mesenteric will supply to the hindgut. So what is the foregut structure? Of course, stomach. So the stomach is in the foregut. So stomach plus supply came from the celiac vessel. So intestine in the midgut, small duodenum, jejunum, and ileum, and of course ascending colon, transverse colon, up to the right 2/3 of the transverse colon. At right 2/3 of the transverse colon, it is conned by the superior mesenteric, and left 1/3 of the transverse colon down to the descending colon, it is the inferior mesenteric artery. So I hope you have some knowledge of this blood supply of the intestine. Yeah, and don't worry about these, twisting and folding of the intestine. But I want you to remember greater omentum and lesser omentum. Lesser omentum here, lesser omentum is extending from the liver to the lesser calf of the stomach, and greater omentum is the big double layer peritoneum covering the rest of the abdominal cavity. So mesentery, peritoneum, omentum, they are all the same structure. Like, this peritoneum is trying to line the whole intra-abdominal cavity. And sometimes they have double layer fold, and that is what we call mesentery. And I want you to remember those organs which are intra-abdominal but retroperitoneal. And I want you to remember those which are intra-abdominal but it is intraperitoneal organs. So it is easy to remember retroperitoneal organs, which are pancreas, which are duodenum, pancreas, and kidneys. And of course, ascending colon, descending colon, they are posterior to the peritoneum. So transverse colon has transverse mesocolon, and small intestine has small intestinal mesocolon. Don't worry about this anymore at this stage. This is the revision. And supracholic compartment, intracholic compartment, and the greater sac and lesser sac. The continuation site is epiploic foramen. So gastrointestinal tract, retroperitoneal organs, and retroperitoneal organs, intra-abdominal retroperitoneal organs, and intra-abdominal intraperitoneal organs. I want you to remember. So now if we look at that, look at this, where is it? Here. You can see the spine. Spine is in the posterior. So you can see the two rectus here. So this is the liver. So this must be the right side. You can see the spleen here. This must be the left side. So you are looking at somebody from the bottom up. Right side, left side, posterior, anterior. This is the liver. That's the orientation. And if you know that, you can appreciate this CT scan, CT scan. Hey, right kidney, left kidney. You can see the pancreas, which is stuck to the posterior abdominal wall. Yeah, posterior abdominal wall. Okay, then let's keep moving. That's a bit more. The job of the gastrointestinal tract, I believe we all know that. It is written here. I'm not making any question out of this diagram because it is easy to remember, and this is the common sense. Hey, forget mid-get, high-get structures. So mid-get, try to remember mid-get. It starts from the duodenum, lower half of this duodenum. It goes to the proximal two-thirds of the transverse colon. So mid-get structure, the blood supply, they will get from the, mainly from the superior mesenteric artery. Of course, some of the structure like duodenum, we get blood supply from the celiac trunk. Yeah. So try to remember foregut, midgut, hindgut, and their blood supply. Serous peritoneum, peritoneum membrane. Like I'm going to skip this. Mesentery. Yeah, don't forget mesentery. Mesentery is nothing more than the peritoneum, double layer peritoneum. That is what we call mesentery. Yeah. It will contain blood vessels and nerve. Okay, ventral mesentery, secondary. This is we have talked about recently, so I'm not going to repeat that. Embryology. I'm not going to repeat the embryology. Hey, layers of the gastrointestinal tract. Yeah, layers of the gastrointestinal tract. Like we all say, everything is 3 except gastrointestinal tract, which is 4. The gastrointestinal tract, which is 4, they are mucosa, submucosa, marcellia, muscularis externa, and the serosa layer. So we have to be quick, you know, to remember things. So we have to remember the intestinal motility nerve, the nerve for the intestinal motility. It is here, in between the inner circular and outer longitudinal layer of the marcellia. That is what we call myenteric nerve. Hey, in the submucosa, we still have the nerve. That is what we call submucosa plexus. So mucosa has epithelium. Epithelium will sit on the lamina propria, which is the loose areolar connective tissue. And there is a small muscle, which is the muscularis mucosa, which is not for the intestinal motility, which is only for the secretions of the intestinal glands. And look at that here, the glands, intestinal glands from the submucosa will come into the intestinal lumen. So that is important for these smooth muscles are important for the local movement, not for the gastrointestinal motility. And don't forget the nerves, the submucosa plexus and the myenteric plexus. Myenteric plexus is important for the muscles, which is for the movement of the gastrointestinal tract. And I'm going to skip it. The oral cavity, I'm going to skip it. These muscles, like a few important muscles of the masseter, like bassinator, bassinator, and this pharyngeal constrictors. These are the muscles of the pharynx. Yes, superior, middle, and inferior pharyngeal constrictors. It is a little bit detailed. I might not ask in the exam. So digestions, some mucosa, submucosa, these 4 layers. Now I believe you all know these layers of the mucosa. Epithelium is for absorption and secretion, and therefore the epithelium, we will use the columnar epithelium. Columnar epithelium is tall and long, so it can function a lot, not like a flat squamous epithelium. And epithelium, we have to sit on the loose connective tissue, which is what we call lamina propria. And just outside the lamina propria, we have the small muscle layer, which very tiny little small. This is called muscularis mucosa. And epithelial tissue, yes, we submucosal layer, loose areolar connective tissue, blood vessels and nerve, lymphoid tissue. Hey, here we, and the muscle layer, inner circular, outer longitudinal, inner circular, outer longitudinal. In between inner circular and outer longitudinal, in between inner circular and outer longitudinal, we have the in between inner circular and outer longitudinal, we have the myenteric nerve plexus. Yeah, inner circular and outer longitudinal, we have the myenteric nerve plexus. The inner circular layer, we squeeze the gastrointestinal tract. Outer longitudinal, we shorten the gastrointestinal tract. Combination of this will give the peristalsis and segmentation movement of the gastrointestinal tract. Serosa, hey, serosa is, everyone knows, smooth muscles. Hey, smooth muscle. We talk about smooth muscle, but I don't think I will ask many questions about smooth muscle in the exam. So don't worry about smooth muscle, but I want you to have a good knowledge of smooth muscles, where we can find smooth muscles in our body, and what is the shape of the smooth muscle, and what is the difference between skeletal muscle and the smooth muscle. Yeah. So I hope I haven't make any question for the smooth muscle. So it is good to know, and therefore don't worry about smooth muscle. Cytoskeleton, contraction of the smooth muscle. Yes. Myenteric plexus and submucosal plexus, that is important, you need to know. And autonomic nervous system, no, it is not in this exam, because it will come in the nervous system lecture exam. But what I want you to remember is parasympathetic will increase the movement of the gastrointestinal tract, and sympathetic will decrease the movement of the gastrointestinal tract. And so this is layers of the stomach. I believe I have made questions about the stomach. This is the dome, is called the fundus of the stomach, body of the stomach, pyloric portion of the antrum portion of the stomach, lesser curvature, greater curvature, and stomach has one more extra layer muscle, which is the oblique. So oblique, circular, and outer longitudinal muscle. The glands which secrete, which hormone, pepsin, hydrochloric acid, pepsinogen will become pepsin, which is acted by the hydrochloric acid. Stomach will absorb water, electrolyte, and it will start digesting the protein. Protein with pepsin. Pepsin is from the pepsinogen. Gastric acid change pepsinogen into pepsin. And these few little stomach glands, I want you to remember that. I believe I have made questions for these small little glands, like hydrochloric acid, Brighter cell, intrinsic factor, Brighter cell. Chief cell will produce pepsinogen. Pepsinogen will be converted to pepsin, pepsinogen to pepsin by hydrochloric acid. Hydrochloric acid is from Brighter cell. So these little stomach glands are important. So I believe, you will have to study that in the, the physiology lecture as well. So I think it is worth studying, because we need to know both physiology and anatomy. And this is the anatomy segment of this gland. It's not a lot. I want you to remember that. The duodenum, jejunum, I don't think there are many big questions I can make. And stomach anatomy, no, liver anatomy, hepatobiliary anatomy. So don't forget this hepatobiliary anatomy. Duodenum loop, C shape. In the loop of the duodenum, the head of the pancreas, body of the pancreas, and tail of the pancreas. The gallbladder is stuck in the inferior surface of the liver, and gallbladder will come out as a cystic duct. Cystic duct will join with the hepatic duct. Combination of cystic and hepatic duct is called common bile duct, which will join with the pancreatic duct, big pancreatic duct, main pancreatic duct, and we open into the duodenum at the ambula of Vater. So that is the important anatomy. And this, we all know that already, like hostration, Taenia coli. And this is rectum and anal canal. Rectum and anal canal anatomy is important. Why is that? Look at the pectinate line at the base of the anal columns. So anal columns, which will create anal valves. At the bottom of the anal valve, we have the pectinate line. The importance of the pectinate line is outside of the pectinate line, the sensation is somatic sensation. Inside of the pectinate line it is the visceral sensation. So if we touch and if we prick the skin of the anus outside the pectinate line, we will have pain. But if we push the surface, mucosal surface inside the pectinate line, we will not feel pain. It is more for the autonomic nervous system sensation. Rectum and anal canal, and the anal sphincters, internal anal sphincter and external anal sphincters. External anal sphincters are skeletal muscles, which is under voluntary control, and internal anal sphincters, which is the continuation of the longitudinal and circular muscle of the gastrointestinal tract. It is smooth muscle, it is involuntary control. So let's say if the situation is not good, we try to control ourselves. That is the external anal sphincter, which is the skeletal muscle, which is the voluntary control. Liver, right lobe, left lobe, posterior surface, caudate lobe, the quadrate lobe. So I want you to remember these lobes. And this anatomy, I think I have made some questions on this diagram. So it is liver posterior surface anatomy, which is important. Liver lobules. Get the liver, look at that, you will see hexagonal lobules. And that hexagonal structures are called liver lobules. In the center of these hexagonal structure is called central vein. So at every corner of the hexagon, we call the portal triad: artery, vein, and the bile duct. So that is this anatomy is important. Look at the liver cells, which is like a cuboidal cell, which will secrete bile, and the bile will be taken away by this lymphatic drain. The bile ducts. Pancreas anatomy, pancreatic acinar glands. So like pancreas has got both exocrine and endocrine function. And I hope you remember endocrine is ductless gland, like insulin, glucagon will be secreted directly into the blood vessel. Like bicarbonate from the pancreas gland, we have to go inside the pancreatic duct, and finally we have to open into the. All right, guys, what's the time now? It's like about 12 o'clock. Has anyone got any particular question? So if you have any question, like just get in touch with me today, tomorrow, and Friday, no class. I want you all to I want you all to do all the homework